چرا هیچی نمیگه؟ بابا چیکار به بقیه نگیم؟
Hi, dear audiences, dear participants, especially our dearest lecturers, dear Professor Borna, dear Professor Trehan, and also dear Professor Srinivasan. Welcome to the panel.
Thank you. It's an honor to be here.
The honor is for us.
Thank you.
Thank you so much. It's nice to be here.
Nice to see all of you. We are starting in just 2 minutes, according to the Tehran time. Dear Professor Borna, we are going with you at as a first lecture if you are ready and if you let us.
Yes, I'm ready. Anytime you're ready.
Okay, thanks. Again, all honorfully, we are starting the panel of nutrition and development in the 32nd International Congress on Pediatrics. Welcome all, and we are so happy and so honorful to have you all together. We are going to be with you with 5 distinguished and awesome lecturers from many parts of the world. We are going to have a very, very good time together with awesome and informative lectures. I want to just remind that the panel will be broadcasting live on YouTube channel of Children's Medical Center. And also you can find out all the lectures and recorded videos on the Congress website, Telegram channel, Petcong, and also you can get the information about the panel on the all social media parts of the Congress. For Iranian audiences, if you want to get CME credits, you should register at the website of cme.ir, and also to be qualified for the panel and getting the credits, you should pass the special quiz for the panel up to 48 after the finishing at cmequiz.ir. I'm sure that we are going to have a good time together. Honorfully, we are starting the first lecture with dear Professor Reza Borna from Santa Monica Medical Center, UCLA, USA, with the so exciting topic of childhood obesity. Dear Professor Borna, we are with you. خوش آمدید.
Thank you. Thank you for having me. So let me share my screen. So let me share this here. Okay, are we good? Do you see me?
Yes, the
Perfect.
awesome slides, the awesome presentation.
Yep. So good morning in my time and good afternoon in your time. My name is Reza Borna. I'm a pediatric anesthesiologist at University of California, Los Angeles, UCLA. And today I picked up an important topic, which is childhood obesity. This topic is very important for us for so many reasons. For me, as my job as a pediatric anesthesiologist, we are facing a lot of obese children every day. And overall, globally, it's a very important topic. So let's start. The question that I really like to ask at the beginning is, are we facing a serious medical condition? And eventually you're gonna see the answer for the US itself is definitely yes. And now we can say the answer for the whole world is also yes. And the number of obese children, the number of obese people overall, and specifically obese children, is increasing significantly. And this is something very important for the healthcare. So I'm trying to do a little bit of definitions and then the incidence and prevalence of obesity in children, and also finding the risk factors and the comorbidities that we see with this problem. So these are the topics, 1, 2, 3, 4, 5, how many? 7 circles that we're gonna focus today. Let's start with the first one. So what is the definition of obesity? Whenever we talk about obesity, we always go to BMI. The BMI less than this is normal, this is the overweight, and then obese. But the major question is, can we use the same scale when we're talking about obesity in children and adults? Can we use the same definitions for children when we're talking about obesity? Let me show you a very nice picture. So the boy on the left, the one with the red shirt, has his height is 1.42, 1 meter and 42 centimeter. His weight is 46.2, and his BMI, based on the calculation, is 22.9. So technically you can say this is a normal BMI, but as you see, this is not a normal kid. This is an obese kid. So just using BMI does not help us. So what can we do? So starting maybe, I don't know exactly when, but around maybe 10 years, 15 years ago, instead of using BMI, we start to use just the pure number of BMI. We start to use the percentile of the BMI. So based on this definition, as you see on the right column here, for the age 2 to 18, we say if the BMI is less than 5 percentile, that kid is underweight. If the BMI is between 5th and 85th, that's normal weight. Anything above 85th up to 95th is overweight. And whenever we have BMI more than 95th percentile, that's called obesity. So with the percentile of the BMI, we can define obesity in children better. So what's going on with obesity in the whole world? We have a lot of data in the US because this obesity in the US is a major healthcare issue. So CDC has focused a lot on this issue. So I just want to show a few graphs here and see what do we have. This one is just for adults. This one for adult, and as you see, this is the left side is the total number, and then in the middle we have men and women. Based on different age groups. Most of the time, as you compare men and women, the women have higher chance of obesity in different age groups. But let's go to our part of the interest, which is the children. The CDC in 2016 and 17, they divided the kids to 3 groups, and group 2 to 5. One second, sorry, can I put this here? Yeah. So group 2 to 5, 6 to 11, and 12 to 19. And as you see in these 3 different color, and the left one, the dark blue, is the total number. Again, as you see, the number is high. The total number of the obese children in the United States between the age of 2 and 19 is 18.5%. And this is for the adult based on the race. I don't want to go to the details of this one, but as you see, I just want to give you the heads up about the females versus males. This column here on the right side, the lavender color, this is the women, and these are non-Hispanic, Black, African-American women, and they have 54.8% obesity. That's the highest race / gender group in the US, 54.8%. So this is the same with the kids with the same result. So let's go back here. I want to show you something. So as I said, in children, we have 18.5%. So if we know the population of the US and the children, 18.5% is 13.7 million of the children in the United States, they are obese. Just to give you a heads up, what is 13.7 million? Just some of the countries in the Europe. Sweden has 10 million population, Portugal has 10 million, Greece 10 million, and Belgium. Obese children in the US is more than the population of any of these 4 countries in the Europe. That just gives you how many obese kids we have. And as you see here, the growth of obesity in the last 20 years almost, it started in 1999. The top one is for the adult and the lower one is for the kids. It has almost the same pattern. The pattern is almost the same, not exactly identical, but almost the same. This is a very nice one. This was a study done in 2017 in George Washington University, and they said at the age 2, they found how many percent of the kids in their study has obesity, and the answer was 9%. Then they used the data about the whole prevalence of obesity in the country, and they say that if these kids right now at the age of 2, 9% of them they have obesity, what happened when they are age 10, the number will become 26%, age 15, almost the same thing. At the age of 20, that's 32%. Then they go up at age of 25, 46, age of 30, 55, and the top number is age 35, 59% of those kids are obese. So as you see, the growth is significantly fast. And by the age of 35, 59% of those kids become obese. And this was published in 2017, and it was by George Washington University. So quickly go through the map of the US, and then I'm going to show the map of the world. As you see here, this is for adults age over 18. This is the prevalence, and the blue one is when the percentage of obesity is between 33 to 38. As we're in the election time in the US, if you compare this with the map of election, all these are red states, if you know what I mean by red state. So, and then this is for the kids between age 9 and 12, and then the last one is for the kids age 2 to 4. As you see, still a high number of states have obesity in the US. I want to show you this. They said that since 1970, so as I show in the map and the numbers in the United States, the prevalence of obesity in the United States is very high. But this is not just the US. Everywhere in the world is being affected by obesity. And they say since 1975, the prevalence of obesity in the whole world has been tripled, 3 times since. I show you some numbers. They said in an adult 16 in the whole world, we had 39% overweight, which is 1.9, close to 2 billion people. And if you come to the lower part, which is the children under the age of 5, 41 million obese and or overweight we had. This number was 32 million in 1990. And age 5 to 19 overall, 340 million obese overweight. If you had number I showed you on obesity has been tripled, but look at the children. In children, the situation is even worse. In children, in 1975, only 1% of the children they were obese, but in 2016, 6% of girls and 8% of boys they were obese. Yeah. So let's go to the map of the world. A little bit better here. The whole world. The countries with dark blue are the one which have the whole world for the adults.
Dear Professor Borna, we are having a little bit problem with your voice. I don't know, maybe it is from your internet connection or something else, but your voice is completely interrupted. Dear Professor Borna?
Hello?
Do you hear me better?
Yes, yes, yes. It's better now. I'm so sorry for interrupting.
Hello? Looks like, I'm sorry. Can you hear me now?
Yes, it's better.
Wait, okay, sorry for that. So this map is the map of the whole world. As I was saying, that the prevalence of, let me make it bigger, the prevalence of, if the number we're looking for the countries with more than 30% prevalence, it's only 3 countries. US is here for sure, Saudi Arabia and New Zealand. This is the number. And then just having what's going on in Iran. Iran is in this kind of lighter blue, which is 10 to 19%. And this number in Iran, 10 to 19%, matches with few studies that we have in Iran regarding obesity. And this is for women. The first one was for men. And this, when we go for women, we have more countries in dark blue. And now, unfortunately, Iran is also included. And again, this number is matched with what I'm going to show later about obesity in Iran. As you see, more countries as a US, Mexico, some countries in South America, North Africa, Saudi Arabia, Iraq, Iran, Turkey, and those all countries are, in women, they have more than 30% prevalence of obesity. And this is the whole in different men, top is adult, and the lower one is the kids, boys and girls, the same pattern of obesity in the whole world. But now there's a question: if there is an obese child, does he or she become obese adults? There are many studies proven that yes, the answer is most often they have high chance of become obesity. So that's why the focus of the whole public health is back to children, to see if we can fix the problem at that time. Eventually, when they grow up, the chance that they become obese is become less if we can focus on the lower ages. How about the parents? Having an obese parent, does it affect? The answer is yes. So if you have one parent who is obese, the chance that the child become obese become 2 to 3-fold. And if both parents are obese, the chance that the kid become obese is going to become 15-fold. That number is really, really high. And now, recently in the United States, they're focusing that as a parent, if you cannot fix this problem in your child, are you responsible? And there are some studies, I would say articles, especially in the law system, that they're trying to say that maybe this is some sort of child abuse if you are obese and you let your child become obese too. So this is the study that I was talking about in Iran. And the study was done in 2016 by, I don't know any of these names, but this was done in 2016. And almost we are seeing the same numbers that I mentioned before. This light blue lines, look at this. In males, we have 15.3%, and in females, we have 29.8% obesity in Iran. So if not close to US, but also Iran is not in a good shape in terms of obesity. And this is the map. As you see, the left side is the females, and all the darker colors, it means they're obese. Middle column is the males, and both sexes go to the right column. So as you see, on the left one, the females are really affected. The top one is in the rural area. The middle one is in the urban, the big cities. As you see, again, more number, higher chance. So overall, I would say this map on the left column middle, which is the females in the cities, of course, in Iran, they have the highest chance of obesity compared to the other groups. So let's talk about the etiology. There are a lot of things affecting this and can cause this. I don't want to talk about, for example, in the bottom, you can see medications, some genetics, some endocrine disorders. Those are something obvious. I cannot go look at the kid who's taking the steroids and become obese. That's not his fault. He has to take that steroid. Forget those things. Let's focus on the things that we can change. We can work on it. The number of things comes to this soda, which we call them sugar sweetened beverages, or technically soda of this Coca, Pepsi, and Fanta, those things. So let's see that. This was a study done in 2013, and that was in Harvard. And definitely they found a very, very direct correlation between using these beverages, drinking these beverages, and obesity in children and adults. What else? The second thing is definitely the fast food. The fast food services are growing everywhere in the whole world, specifically in the US, and that caused a lot of problems with obesity. This is a very wonderful study I want to show you. This was done in 2000, I don't find, but it was done in Baylor, Texas, and in 2011. And actually, they came and they checked the schools, and they found if the school is half a mile, if I'm not wrong, yes, half a mile. If the school has a fast food restaurant less than half a mile close to the school, comparing to the other schools that the fast food factory, the fast food restaurant is more than half a mile. They compared these two types of schools, and they found the schools with access to the fast food, the kids, they use and they eat less fruits and vegetables. They consume more sodas like the Coke and Pepsi, and the chance of the prevalence of obesity in the kids with access to fast food for restaurant close to their schools is higher. It was so obvious that this is affecting the life of the children. The other thing we are missing is recently everybody's taking the food and go to his or her room and sitting next to the computer and eating without having the family meal. And I'm going to talk about family meal later. That's another thing that is affecting our children. How about TV and video games? How they are affecting? Definitely, that's a big factor. Why? One thing is obviously, if your kid is sitting next to the TV or any games, they don't have any physical activity. They don't go out and they don't exercise. They don't play games outside the house. But there are a few studies interesting for me to show, very interesting to show. In 2013, this was also done in Harvard, and they found that if the kids are spending any extra hour on TV and the video games, the chance that their BMI increases is for each hour, the BMI increased by 0.09. That's a big number. I mean, if on a weekend, on an average, the kid is spending, let's say 3-4 more hours per day, their BMI is gonna be increased certainly by half a point. So this is a very obvious thing. And this is another study which is showing the same thing. And then I like to talk about the bedtime. When the kids are playing a lot, they go to bed very late, and that's another factor. This is something that we know right now. It's a very new data that we have. This was published in 2016. In the past, we knew that less bedtime is going to have effect on the kids' function, but how about obesity? In this study, they checked the preschool children and they divided them to 3 groups. 25% of them, they went to bed at 8 p.m., 50% between 8 to 9, and 25% after 9 p.m. they went to bed. And the prevalence of obesity was 10%, 16%, and 23% on each of these groups. So the kids after 9 p.m., 23% of them are obese. So just having the length of the sleep is also affecting the obesity. As I said, medication, those things, but overall, as you see, these different things are affecting obesity. Can we change any of these? Of course we can. And this was a nice study. This was done in Ohio, University of Ohio. And they came and they gave 3 routines to the kids. And they said, okay, how about having dinner with the family, having enough sleep, and limiting the time of the whole screen time, including computer, TV, and video games. So let's review one more time. Having dinner with the family, more sleep, and less screen time. And then they found if the kids have all these 3 routines, the chance of obesity is less in these kids comparing to kids with none of these routines. So simple changes in the routines of the kids' everyday life can affect obesity too. But what are the consequences? The health consequences of obesity is obvious. The first system that I like to talk is cardiovascular. We know that they're always it's obvious to every one of us that obesity is going to increase the chance of blood pressure. It's published in the past, and this was done 2007, and the previous study was published in 2013, and this was showing that obviously the obesity is going to increase the chance of high blood pressure. The other cardiac problem, like increased LV mass, any problem, eventually heart failure comes with obesity. How about the lipid system? Of course, obesity is going to increase the chance of increase the level of LDL, TG, triglyceride, and drop the level of HDL. How about diabetes? The role of obesity in diabetes is also obvious. This was a study published in 2015, and it was done in somewhere, if I find the proper North Carolina. This is in North Carolina, and they found that 18% of overweight and obese children, they are pre-diabetic. So that's an obvious number and it's significant. What about this gallbladder or the whole GI system? And I see this every day, that the kids with obesity, they have higher chance of reflux or GERD, we call here GERD. And the fatty liver, the non-alcoholic fatty liver, the chance is higher in kids with obesity. And then when they grow up, when they become adults, the chance of all different kinds of cancer, breast, pancreas, endometrial cancer, prostate, and colon type, different type of colon cancers is increased. And we have several studies to prove that they have higher chance of obesity, they higher chance of cancer in obese patient. The one that is important for me is affecting my everyday life, and it's affecting maybe some other specialty, is the OSA. So we know that it's obvious that there are different studies with different numbers, but all of them are giving us high number, that the minimum is saying that 10% of children with obesity have severe OSA, symptomatic OSA. But this is another study which was done in 2012, and they say that if BMI is more than 97th percentile, more than 97, which is severe obesity, the chance of OSA becomes 45%. That's a huge number. And all those kids with OSA, when they come for any surgery or everyday life, they have a lot of complications, a lot of comorbidities which comes with OSA. How about asthma? There are several studies showing that if you're obese, there's increased chance of asthma. And if you have higher BMI and asthma, your asthma is more severe. So just having being obese increase the chance of asthma. On top of that, the obese kids, they have more severe asthma. This is another, it's like a type of syndrome, we call that obesity hypoventilation, that these are the kids that during the sleep, they have different sort of problems, including hypoventilation and episode of apnea. They monitor several of these kids in this study, and they found 17% of them, they have major events during the night when they're asleep, and saturation drops to below 85% most of the time, which is definitely not a good situation. But something that recently we're focusing on is the psychiatric. I mean, the behavioral change that we see in these kids. These kids have a lot of problems. They develop anxiety and depression. Most of them becomes when they're bullying at the school and social life in front of friends and families. They eventually develop anxiety and depression. The self-esteem in these kids is significantly lower, and the quality of life eventually is lower in kids with obesity. So as I said, and as you saw these numbers, this has become a global problem. And the WHO started maybe around 2015, they started to say, hey, we should focus on this, especially on childhood obesity, because with focusing on childhood obesity, we can eventually, maybe in 20 years, help to drop the number of obesity in adults, because these kids, they're going to become adults in 20 years. So this is called a WHO-led Commission on Ending Childhood Obesity. They're starting doing some publications, but at the moment they have six steps that they're focusing on childhood obesity. One is having healthy foods. 2 is promote physical activity. 3 is preconception and pregnancy care. That's something that they think that they can also go and target the pregnant woman and become sure that that time they're not having obese child. And so focusing even at that time, it might help. Then early childhood, the diet and physical activity. Number 5 is health, nutrition, and physical activity for school-age children. And eventually, if for any reason these kids become obese, we should focus on weight management. So I dropped my slides to fit on 30 minutes, and I think I'm out of time, and I'm open to any questions.
Many thanks, dear Professor Borna, for your very nice, exciting presentation and also very good applicable information. If may you follow, there are questions in the chat section. Do you want me to read or you want to read yourself and answer?
Actually,
Which one do you prefer?
I don't. You can read the first question. I don't
Okay. They ask that if genetic mutations are associated with, are associated with childhood obesity, and if yes, does it cause early onset obesity or not?
So that's the answer is yes. The reason I didn't focus on that part, because the genetics is something, and like the disorders, like the medication, these are not something that we can change. But definitely the answer is yes. And the kids with, as I mentioned, the parents, if both parents are obese, the chance is 15%. That means combination of behavioral changes in the house and the genetics. And of course, we can detect that right now. What they do that we have not obesity. We have I forgot the name, but we have some part of our endocrine system here at UCLA, and they focus on obese children, but not at the age of 14, 15 to 16, at the age of 1 and 2. When they come around for the routine checkup, they detect those kids and they do genetic testing and become sure this is something fixable or not. Because if it's genetics, technically you cannot fix it. You just have to do weight management. But if it's not genetics, then you can focus on the other factors. The answer is yes.
Thanks a lot. Also, can these mutations cause eating habit disturbances? They cause eating habit disturbances, and obesity is caused by eating habit and not mutation itself. Can we expect to be able to control obesity in obese children with mutation by alteration in eating habits?
So I would say that's a tough question, because just change, if the kid is genetically involved, you cannot treat the obesity itself. You can stop growing it. You can stop making it worse, number one. Number two, if you think that the child is obese genetically and there's some problem in the genetics, then that kid needs a very, very, very restrict management of the weight. There are specialties here to just focus on the weight management. And eventually, some of these kids, when they become teenagers, they're gonna have surgeries to like a gastric band to stop the eating too much. Because if genetically they're involved and in their head they have to eat a lot and a lot and a lot, they need to have surgery.
Thanks a lot for your complete definition and complete answer. And again, thanks for accepting our invitation and joining the panel. If you have any comment or anything, we are all ready to hear that. If not, we can go to the next panelist.
Thanks for having me, and have a wonderful day.
Thanks a lot. Take care. Have a wonderful day. Again, audiences, welcome to the audiences that join us between the presentation of Professor Borna. I hope as well as all of us, you are having a very good time. As a next step, we are having our next distinguished guest and dear Professor Amita Trehan from Postgraduate Institute of Medical Education and Research, Chandigarh, India. Welcome, dear Professor Trehan. It's a big honor to have you with us, and it's a big chance to having you and seeing your lecture. I just want to say a special sentence to you. I hope that I'm going to say it right. Panel में आपका स्वागत है हमारे निमंत्रण को स्वीकार करने के लिए धन्यवाद.
Thank you so much. And that was perfectly worded. That's very sweet of you. Okay. And thanks to the university for inviting me. It's a real pleasure to be here to participate in your beautifully organized session.
It's your
So,
kindness, dear professor, and it's
yeah.
our bigger pleasure and honor. If you are ready, you can start sharing
Yeah,
your screen,
yes.
and we are all ears with you.
Okay, thank you. Is this fine, Maya? Yeah? Is the screen visible? I couldn't hear you. Is the screen visible?
Not yet, dear professor. Please
Oh, I'm sorry.
put
I just
on.
checked. Yeah,
Okay.
I just did. Yes.
Shall I help you in defining the way of sharing or not?
Yeah, it was sharing. It just disappeared. Desktop. 1 minute.
It's wonderful. So such a beautiful sea and beach.
Yeah. I got it.
Okay, we are with you, dear professor.
Yeah, perfect. Right. So thank you all again. And I am a pediatric hematologist oncologist, and I work in one of the institutes in the north part of India. So from obesity, which was a wonderful talk, we really got to know what's happening in the world. I'll just go on to a slightly different topic. Now, as already mentioned, we know that adequate nutrition is fundamental in the growth and development in children. And children with cancer are no exception. We also appreciate the fact that the number of children who are undernourished across the globe is high, predominantly being in South Asia and Southern and Eastern Africa. And now this possibly is going to increase with the current coronavirus pandemic owing to a lot of economic depravity. So incidence of malnutrition and diagnosis in children with cancer is high. And we look at the figures across the globe. This is very high in South America to the tune of nearly 50-60%. And in Africa, it goes up to as high as 70%. Even the developed and high income countries have reported nearly 20 to 30% patients who are undernourished at diagnosis once they're diagnosed to have cancer. So malnutrition is a serious impediment in cancer treatment. So what happens is that, yes, number one, when you have cancer, there is reduced appetite, which is because of the cancer per se, because of treatment, decrease in food intake, a negative balance, and that results in weight loss. Along with the fact that 50 to 60% of children with oncology children present or develop malnutrition while they're being treated for the cancer. In addition, there is increased complications. Once they're undernourished, there is decreased tolerance to a lot of things I'll come to later. There's poor response to therapy, an increased risk of infection, and which ultimately results in a diminished quality of life. In addition, it's a known fact that once children are undernourished, a very high number, nearly 20 to 40%, can die of complication, which is more as a result of poor nourishment rather than the primary diagnosis. So essentially what happens is a nutritional intervention is needed, which increases the nutrient intake despite a patient being unable to take very well. So that is what is actually required in an undernourished child. So now literature abounds with a lot of publications which focus on the assessment, intervention, and the impact of nutritional status on the outcome of treatment. So a lot of them are, most of the literature reports that yes, undernourished children do not do well. However, it is also a recognized fact that obese children do poorly also. So literature has now, has come up with that being obese or underweight at diagnosis during the treatment and after has resulted in an inferior event-free survival. So essentially, it points to the fact that neither we be obese, as Dr. Borna has pointed out very well, or undernourished. Both of them have implications on us. So coming back to the simple thing of why is nutrition good and important, especially in children who have a malignancy. It's a good nutritional state will result in an improved tolerance to chemotherapy. There's better survival. Automatically, if you're well nourished, there's an improved quality of life. So your physical and psychological development is good. And there is a decreased risk of infection. So if we look, sorry, I went back. So now what really happens in nutrition? Now, when you're undernourished or overnourished, etc., there is your body composition changes, which affects the pharmacokinetics of many drugs. And this automatically results in the alteration of the pharmacodynamics. So it's a fact that when children with cancer are undergoing treatment, the obese children have increased hepatic and pancreatic toxicity, whereas the ones who are undernourished have an increase in fungal infections and increase in hematological toxicity, and both of these need to be avoided. So with this background, I'm just going to focus on two important aspects of nutrition in cancer, which is the assessment and intervention, why both these are needed. So assessment of nutrition can be done in a lot of ways. We know the most important aspects of assessment. A simpler tool is also to just scan all children, just do a screening, because we may not be in a position or have the know-how or enough staff to look at them in detail. So a lot of people just look at simple screening tools, which is there in a lot of diseases in pediatrics. And you see if the patient has a high-risk cancer, is the patient undergoing intensive therapy, does he have any symptoms related to your gut, has the child had poor intake over the last week, any weight loss over the past 1 week, and if there are any clinical signs of undernutrition. And a score of 3 or more puts the child at risk of malnutrition. This scan is usually put in practice in places where, yes, one may not have a sufficient staff or enough dietitians to really evaluate a patient. So this is a very simple way of knowing what to do. So we've all been taught about nutritional assessment, which includes your anthropometry, your biochemistry, clinical assessment, and your dietary history. All 4 things come to it. And yet, we have to accept that in day-to-day clinical practice, we are not able to do anything. If we are all fortunate and a dietitian comes around doing it, it's good. But most of us may not be in a position to be lucky enough to have a dietitian who is dedicated to a ward and do all this on a day-to-day basis. So now, the simple anthropometric measurements include your weight, height, length, your BMI, weight for height, which is expressed as Z-scores or centiles as per the WHO. Weight as a percentage of ideal weight for height in gender is also used. 2 important things which are very frequently missed out in day-to-day practice is your mid-upper arm circumference and your tricep skin fold thickness, which most people feel is better for the periphery and the lower where doctors are not available, but I'll come to the why it's important even in tertiary care or university hospitals. So I'm not going to go into detail of the WHO definition, which most of us are familiar with, which looks as per the Z-score, it looks at your height for age, weight for height, weight for age, and your BMI, and the child is either normal, stunted, obese, overweight, wasted, underweight, or severely wasted, depending on where the patient fits. Now, there is some. So now there are a few limitations of your WHO criteria. So one is that we have to accept that in cancer, your acute malnutrition can be underestimated using the WHO criteria, because sometimes the child may have a very big tumor, which if it's more than 10% of the body weight, you'll get an altered weight. The other issue with the WHO criteria is that sometimes chronic malnutrition is overestimated in populations who are genetically short stature. So that's why there are some problems with the WHO criteria. And as already mentioned, that your weight can be distorted by a large mass, which will underestimate your nutrition. Changes in hydration and fluid shift your weight, affect the weight. And the other important thing is that your BMI does not distinguish muscle from adipose tissue, which is sometimes very important, especially when you have, children. I just come to sarcopenic obesity. So now, whenever we talk about nutrition and undernutrition, etc., there's a lot of focus on low middle income countries. And the reason is that more than 85% of children with cancer belong to the developing countries, where the prevalence of malnutrition may exceed 50%. And as I've already said, nutritional status can influence the outcome of malignant disease, and ultimately that affects your survival. So now coming to the important two tiny things, the MUAC and tricep skin fold thickness, which all of us are taught in medical schools and all, but you kind of put it that this is used in, rural areas. Now, these are actually markers of your lean body mass and fat mass. Your mid upper arm circumference gives us a good estimate of your lean body mass, and the tricep skin fold thickness tells us about the fat mass. And these two parameters are not related to your tumor masses. In addition, normative data are available in the pediatric population up to the second decade of life. So that helps a lot. I just come to this. So the St. Jude's Hospital in the United States has given a very simple algorithm which can be used universally to assess the nutritional status when a detailed evaluation is not possible, which uses your mid upper arm circumference, tricep skin fold thickness, and the albumin. And there they've seen that adequately nourished is when your albumin is good and your tricep skin fold thickness and mid upper arm circumference are greater than the 10th centile. Inadequately nourished, which could be severely or moderately depleted. The severely depleted is when your albumin is less than 3.2, tricep skin fold thickness and mid upper arm circumference are less than the 5th centile, and the remaining subjects end up being in between. So now let's just have a look at these parameters: the tricep skin fold thickness, mid upper arm circumference, and the albumin. Do we need all three, or is just one sufficient? There's a very elegant study done in the Americas, the Middle East, the middle part of the Americas, the Hopka group of countries, which has shown that if you look at children with cancer, if you used only the tricep skin fold thickness and the mid upper arm circumference, they found 36% patients to be adequately nourished and 46 to be depleted. However, when they added albumin to their classification, 60%, nearly 60% of children were undernourished and only 22% were well nourished, which points to the fact that with anthropometric measures, a biochemical parameter is also required to really adequately assess your child. So the last bit is your measures of body composition. Yes, this is not needed for day-to-day practice, and I just come to why it's important for us to know about this. There are numerous methods of measurement, and usually these are used for research and not in daily practice. And we've all been taught that the dual energy X-ray absorptiometry, or the so-called DEXA scan, is the best method of determining your body composition. What does this do? It gives a measure of your fat mass. It gives a measure of your fat-free mass or your lean body mass, and your bone mineral mass, which is actually the whole body's composition, and the whole thing can be told. We accept that this is not readily available, and even if it is, usually it is just used for research. Now, why is this important? There is something called sarcopenic obesity, which means that a person has less lean body mass, but an increased fat mass. Essentially, that a person is just fluffy with adipose tissue and your muscle is less. This is revealed by measures of body composition, which is your DEXA scan. And this is important because this is recognized increasingly in children with cancer and has been seen before, during, and after therapy. And why is this important? Because obviously, if we know about it, we can intervene in time. It's a known fact that childhood cancer survivors are obese, and nearly 90% of survivors do have one problem or the other. Obesity is seen to the tune of 24 to 50% of children with childhood cancer on long-term follow-up, which means the child with cancer grows up to be a plump adult. A metabolic syndrome is seen it can be from 5 to 30%. The mean BMI Z scores are higher than their peers, and if you compare the survivors with their siblings, the incidence of obesity is nearly double, which brings us to the fact that a child with cancer needs a longitudinal nutritional assessment at diagnosis, during treatment, and even after he finishes treatment. So this means that actually nutrition is a dynamic process. And ideally, we need to measure your body size and composition throughout, compare it with standards, and it's needed to estimate your nutritional needs and to evaluate your nutritional status and intake adequacy. Of course, your history and examination are vital. I did not go into that for paucity of time. So the next part of my talk is focused a bit on nutritional therapy, which is your oral, and the most common important methods of doing this is your oral intervention, enteral intervention, and parenteral intervention. I'm going to focus on your oral and enteral because this is too vast a topic. So if simple book teaching for nutritional intervention is if you have more than 5% weight loss, or if your centiles for weight for height, BMI, height for age, weight for age are less than the 10th centile, and the nutrient intake is less than 80% of your estimated needs. So what are the interventions possible? Obviously, the simplest one is number one, you start counseling and oral feeding, ensure that the patient is taking well. This is irrespective of the disease. Enteral tube feeding, parenteral nutrition. However, there are no comprehensive validated universal guidelines. Everything is literally individualized from institution to institution. So when we look at enteral nutrition, I will concentrate on this part. It could be oral nutritional supplements. And if you look at enteral, which is your tube feed, this could be gastric, duodenal, jejunal, and a whole lot of types of feeds, etc. are mentioned. Now, the most commonly easiest used are your nasogastric feeds. The others which can be used are your PEG, jejunal, which is used in certain situations. But commonest in pediatrics would be a nasogastric feed. Again, if you look at the roots of nutritional therapy, is your enteral feed. Your tube feeding is the commonest when the child is unable to take your full energy requirements through your oral diet, has mucositis, and we know is not meeting his energy feed. So that is the most important time when an NG feed is inserted. Other feeds are done in different times, but I'll just concentrate on this part. So like I said, the interventions, the easiest is the NG feed. A gastrostomy can be used. The commonest one is a PEG gastrostomy, which is used. Of course, it has to be inserted by a surgeon or a trained personnel. And usually it's only when you need it for a prolonged period of time. And very often it's teenagers, etc., who would not like an NG feed hanging in them. Then is when it's used. Total parenteral nutrition, of course, you have prepared bags which are available. 1 liter of a prepared bag could cost anywhere between $40 and $50 US, which is advised when the gut cannot be used and the child is very sick. When a gut can be used is well and a child is not very sick, the gut should be used. We do not use anything but the gut. I leave that to Dr. Srinivasan to go into. And of course, the total parenteral nutrition, it is customized in places where there's an in-house pharmacy. So it's made to the requirement of the patient and not what is pre-prepared. So now when do we start enteral feeding? Yes, as I've already mentioned, when your oral intake is inadequate to support your growth and ensure nutritional depletion, which means that there is inability to ingest your full energy requirements through oral diet for about 3 to 5 days. If there is severe mucositis, which has happened for a minimum of approximately 3 days, you have to have an intact GIT. Very frequently, especially in oncology patients, they have mucositis, neutropenia, thrombocytopenia, and they have felt that no, we shouldn't put it, but these are theoretical risks. If you have a little bit of mucositis, a child is sedated, you can put in a tube. It is only in severe mucositis, like grade 4, when your mucosa will be very friable and you would not like to put in a tube. Neutropenia, of course, is also relative. It could be just, unless it's very severe and the child is very sick, which is not so often the case. Thrombocytopenia can easily be averted by giving platelets. So these are actually theoretical risks. The issue with simple enteral feeding is it is less consistently used across centers. Often the reason given is no industrialized feeds are available, or in the outpatient department, how can you do it? How do you ensure a patient has used it? Most centers would end up having a partial unavailability. So you rely on part industrialized feed and part homemade nutrient-dense food. And when it is not available at all, especially in some low-income countries, simple homemade nutrient food can be given. Now, a lot of people veer away from homemade nutrient food. They feel it may not be safe, or sometimes you don't give this; it has to be from a box. But the only reason is that food safety. Whenever we're using homemade diet, etc., we have to ensure food safety, and that brings us to food and personal hygiene practice, which has to be ensured. And obviously, this is much more important when you're dealing with low, middle income countries. So that is something to remember that yes, food safety when you're using homemade nutrient food. So now when we have to use enteral feeds, a lot of time there are some myths which go with it. People feel that no, there's no need to start supplementation until substantial weight loss occurs. What is substantial weight loss? It's subjective. So they feel that no, it's okay. Like today the child is 10 kilos and he went down to 9.5 kilos in 2 weeks, doesn't matter. We're still giving him chemotherapy. It's okay, let's wait a little while longer. But as doctors, we know that no, even we're giving him chemotherapy, he's already shrinking. So you have to intervene in time. You don't let him kind of shrink further. So you don't wait for that. You know that he's going to be at high risk, so start before. I've already mentioned mucositis, neutropenia, and thrombocytopenia being relative contraindications. Another issue is that people see that all enteral products are the same, and you may not be able to resume oral feeding. That okay, you put in a tube once, then you'll never be able to go back to feed, which is not correct. People go back to feed. There are food myths. Some people will not eat certain type of food, or they want a vegetarian diet, or some other things, or they don't want to eat. That adds on to it. And a lot of time, the family resistance. People feel that oh dear, putting in a tube is like God knows what's going to happen. We don't want a tube. So a lot of simple barriers which come is that sometimes there's lack of appropriate teaching material available, lack of infrastructure, especially in low mid income countries. The dietary patterns and cultural variations are very high. In a lot of countries, for example, in India, where I'm from, we have cultural variations across the country. Every you travel from the north to the south, there's a major cultural variation. Language barriers can occur. There are people who may be, especially if somebody's in another country and all. The mental status of the parents is important for counseling. Sometimes you can have a dietitian available in your outpatients, not in your inpatients, or vice versa. So these are small things that come in the way to stop centers from really thinking about nutrition in a proper manner. But that's not true. We never doubt ourselves. We just have to do things once you have to do it. And I just want to illustrate a simple case which was looked after by us. We are a low mid income country and we managed to bring him out of it with simple homemade diet. There was a small 8-year-old boy who had Burkitt's lymphoma. His weight at diagnosis was about 18 kilos. Unfortunately, he had a very difficult time during his first course of therapy with a lot of septicemia and neutropenic enterocolitis. And his weight went down to just 10 kilos. And as we can see, he looks like a very miserable 8-year-old child. So then we started him on simple tube feeds. We started him about in October, simple tube feeds when his weight was just 10 kilos. I'm not going to go into the details of feeds. This is local made feeds, but needless to say that the simple WHO formulas of F75 and F100 were used with some other added on feeds. So after about 1 month of NG, we added oral, and this NG feed and oral continued. And within 2 months, his weight had gone up to 15 kilos. The supplements which we gave him were simple homemade things which are available across the globe, which were cereal, milk, oil, butter, sugar. His protein was supplied by beans, lentils, soya, and egg, and vegetables for the other part. Simple homemade diet, and the WHO F75 and F100 formulas were used. No industrialized feeds, and we managed to bring his weight up. So we can see that he started smiling after some time like a proper SAM child. His weight went up. This is despite him not being the most compliant little child, because he would keep pulling out his NG and did not eat as per our advice. And 3 months into, after he completed his therapy for Burkitt's lymphoma, he's a happy, smiling 8-year-old. So now when we come to enteral feeding, how do we do it? It can be continuous. You start with a small amount per hour, and then gradually we hike it up if the child is tolerating it. This is usually given by the feeding pump. Okay, it can be bolus when you start it, depending on the weight, every 2 to 4 hours. And then you keep increasing as the child tolerates. We have to remember that whenever we are starting enteral tube feeding, whether we start continuous or bolus, which would be dependent on the child's status, on his needs. A lot of times you cannot start bolus if a child is unwell, you start continuous. But when you increase it gradually. However, we have to remember that we don't increase the volume and the diet at the same time. You first you go up on the volume and then you increase the concentration. If you do both things together, there's high chances of the child developing osmotic diarrhea. So that is something to be looked into with care whenever we are starting enteral feeding on a child. The tiny thing to remember is sometimes places do not have the feeding pumps. So feeding pumps are very useful, but we have realized over time we did not have feeding pumps at our hospital till a few years ago. We realized that the simple IV infusion pumps can be substituted and used as a syringe pump. So this is just to people who might be in a position where they don't have pumps. Yes, this can also be substituted. We learn to adapt. So the nasogastric feeding tubes, we all know that yes, ideally your platelet should be more than 20,000 when putting it in, which a lot of oncology people know that yes, for any procedure you do that. We have 3 types. The easiest ones which we use are the polyurethane ones, which are soft tubes, and silicone are very often not available. They are the most expensive. They're very soft, but they have an issue of becoming, rolling up inside your tummy or turning even inside the nose because they're super soft. And the simple plastic PVC ones are very occasionally used. They're essentially used when the other ones are not available because they're cheap and simple. But they're obviously, since they're plastic, they're a little hard and they do cause patient discomfort. There are some very fine tubes which have a tiny steel or tungsten tip that we have to remember to take out when a patient is undergoing an MRI scan. They're not really used for feed, but just in case it's put in. So now, what should a pediatric cancer unit adopt? At diagnosis, a complete anthropometry should be done. Your weight should be weekly during admission and then at every clinic visit. The children who are admitted can be asked to keep a dietary record, either the child or the mother. It's much easier to ask older children to keep their own record. It keeps them happy, keeps them occupied a little bit. In addition, what I've realized is that, sometimes they tend to do eat a little bit more because they know they have to show it to the doctor the next morning. So, to feel good, because otherwise if they show doctor a blank diary, it's nicer for them to write a little bit so they even if they eat a tiny bit more, it helps. Now, we have to ensure that our resident doctors and the dietitian check the child's calorie protein intake. This does not have to be every day, even every alternate day. So, you could be lucky and have a dietitian who comes to your ward every day. You could have one coming a week. You may not even have one. So the doctors, we do take rounds daily. We see our patients daily. And if we don't have it, it takes just, 2 or 3 minutes extra to check if the child is eating enough or not. So that helps looking after the caloric protein intake. And even if you don't have a daily dietitian, at least, you can tell the dietitian who's in charge of the ward or the hospital that please look into this child. This child is not eating enough. And of course, like if you have a dietitian who visits the ward daily, then it's a different situation also. The dietitian will automatically see the children as per need. So what should everybody do? Yes, your initial counseling, when we tell the patient about the disease, tell him all about the cancer, etc., and your outcomes, at that time, nutrition should also be part of the counseling. Your nurse, doctor, dietitian should explain to a child, the family, what exactly the diet he should be taking and the need of supplementation which might be needed. Enteral feeding counseling should be done much more so in children who are at high risk, which will include the ones considered at high risk are your myeloid leukemias, children getting high dose chemotherapy, or those in intensive phases. Very small children, obviously the ones with transplant, etc., is a different story. These are your main candidates for feed. If your weight loss is approximately 10 kilos %, your NG should be inserted. And yes, home-based, easily available feeds or industrialized feeds can be used. Recently, I attended a small talk where someone told me something which is very interesting, which makes us feel that home-based diet is available. That person mentioned that using industrialized feeds is not good for the environment. And I was wondering how. And she said that yes, look at the amount of tins and the amount of waste which is produced when you use all this stuff. And then it really struck home with me that yes, when we can use home-based simple feeds, why should we add on to the already the amount of waste in the world and add on to this tins, which obviously just go to the bin. So the simple tools we need are your height, weight, mid-upper arm circumference, tricep skin fold thickness, albumin. This may not be possible very frequently because you need the Harpender's calipers, but the rest of them is very easy. You need education to your parents and child, little pamphlets, talks, which are very simple. And supplementation is enteral and parenteral supplementation, which I've just mentioned. So therefore, just to conclude, we should remember that children who have cancer, assessment of nutritional status is easy. It's mandatory. Once you assess, it identifies the need of nutritional intervention to reduce the risk of adverse health outcomes. An intervention, supplements, and enteral feeding is actually very easy and cheap. It's not any great rocket science. So in the words of Hippocrates, if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have the safest way to health. And I thank you all for a very patient listening. Thank you. So I'm happy to take up any questions if there are any.
Thanks a lot, dear Professor Trehan. It was so nice. Of course, we have questions. If you let me, I'm going to ask you.
Yeah, sure, please.
Thanks a lot. Someone asked that, how can we prevent the malnutrition caused by chemotherapy? And is there any special products using for weight gain for patients under chemotherapy?
So we really cannot prevent it. We can just be proactive by checking on them regularly, ensuring that they're taking. So which is why you need to make sure that yes, you're monitoring your child regularly. And as soon as you feel that your child is not taking properly or that there is a little bit of weight loss, we have to intervene. And the easiest way is to start supplementation, and if needed, start nasogastric feeding. And the most important thing is children who are going to get your intensive therapy. It's always better that yes, you have a 2-year-old. You have a 2-year-old who has myeloid leukemia. There is no way that little child is going to be able to take enough calories and proteins. So in that situation, it's much easier to start feeding, put in an NG tube as soon as literally when the child is diagnosed, so that the child doesn't get malnourished. The second part I'd also like to add is that the appetite stimulants which have been used do not have any definite proven role in pediatrics. They have tried them in adult cancer patients, etc. Which is mainly the progesterone hormones, etc., which nobody advises in pediatrics. Cyproheptadine, again, there is no definite evidence that it helps. There are studies, some say yes, it might help, some say it does not help. And there some studies were abandoned because of adverse effects. I cannot remember the whole details. And they found that patients became excessively sleepy with it. So as such, as of now, there is no evidence that any of these these drugs are going to be of help.
Thanks a lot. And dear Professor, is there any contraindication for these supplements during chemotherapy or not?
No, I mean, for simple, there is no contraindication for any supplementation. You have to give the normal supplementation, which you would give any child, any undernourished child. One would use the same for a child with cancer, except that, yes, you just have to make sure that there is food safety, etc. So there's no, a patient is not going to get something which is not hygienic. So food safety is a concern. Otherwise, we really do not stop or tell them that not to use a particular supplement. Kind of everything is okay.
Thanks a lot. You're so kind, you're so sweet, and your lecture was awesome, wonderful as yourself. Thanks a lot
Thank you,
for
Dr.
sharing your
Anjali.
time with us. I hope you
Thank
have a
you.
nice day and days in front. Take care, dear professor.
Thank you.
Again, thanks audiences for participating, and also I wish you're having a very good time as much as we are enjoying the panel. After dear Professor Amita Trehan, we are going to be with our nice and dear Professor Vijay Srinivasan from the Children's Hospital of Philadelphia, Pennsylvania, USA, with early initiation of enteral nutrition with delivery of adequate energy and protein in critically ill children. Dear Professor Srinivasan, we are with you. If you have my voice.
Yes, thank you so much. I am
Thanks a lot.
delighted to be here today, and I am looking forward to sharing my presentation with all of you.
Thanks a lot. You are the bigger honor of us, and we are pleased to see you here, even online. And I want to mention that आपके पास भी होना एक बड़ा सामान है. निमंत्रण को स्वीकार करने के लिए धन्यवाद. I try to do my best. I'm sorry for any inconvenience in pronunciation.
No, you got it very well. Shukriya. Thank you. Dhanyawad.
With love to India, to all Indian people. Okay, dear professor, you are the co-host. If you are ready, we are eagerly waiting for your lecture.
Perfect. Let me make sure I can screen share, and I will. Are you able to see my slides?
Yes, we are seeing your screen. We are all ears.
Wonderful. Well, thank you so much. I really, again, want to thank you so much for this warm invitation to discuss a topic that is very dear to my heart. And I have titled it Nutrition Therapy in Critically Ill Children, Fact or Fiction. I'm a pediatric intensivist, attending physician at the Children's Hospital of Philadelphia, and I have a faculty appointment at the University of Pennsylvania School of Medicine. And I would like to get started. As I get started, I wanted to share my disclosures with you. I mentioned I'm employed at the Children's Hospital and Penn. My nutrition work has been supported by research grants. Many of you might be familiar with the study on glucose control, Half Pint, which was published a few years ago. I also am working with industry on a device called Tube Clear, which actually is like a pipe cleaner to try and unclog clogged feeding tubes. And I also work with some collaborators from the University of Arizona. I am also on several national and international committees, the American Society for Parenteral and Enteral Nutrition, the Society for Critical Care Medicine, and the American Academy of Pediatrics section on critical care, where I am delighted to share my work and influence the field. I don't have any financial conflicts of interest. So I wanted to start by sharing this wonderful photo of Philadelphia. Philadelphia is a city on the East Coast of the United States, the birthplace of American democracy. This is a view from the east side of the city looking to the west. And on the lower left-hand side, you can see the Benjamin Franklin Bridge, which is over 100 years old. In fact, maybe 175, I think, years old. And you can see the downtown skyline. And beyond that skyline is where the University of Pennsylvania and Children's Hospital of Philadelphia are. This is a view of the Children's Hospital of Philadelphia where I work. This is the main entrance. This is the oldest children's hospital in the United States, founded in 1855. And it has a fantastic legacy and it continues to grow. In fact, the discovery of parenteral nutrition happened next door at the Hospital of University of Pennsylvania by Dr. Stanley Dudrick, who tried this in the late 1950s and saved a baby that had had most of its bowel removed because of necrotizing enterocolitis. And now parenteral nutrition is a mainstay in so many of our units across the world. So why do we care about nutrition? I wanted to share this really wonderful quote that I try to read again and again. And broadly speaking, you can argue that the most fundamental requirements for healthy growth and development in young children include loving support and protection by parents and caretakers, adequate nutrition, and adequate sleep. This is by Ronald Dahl, who is a professor of child development and psychiatry in the United States. This is a very touching and affectionate quote. And this is even more important for critically ill children that I take care of, because the only thing we can do for them other than supporting them in the ICU and allowing the body to heal is to give them nutrition, allow them to sleep, and have their parents be with them to take care of them. So the objectives of my talk are twofold. One, I want to examine the evidence for timing of initiation of nutrition in critically ill children. And two, I want to evaluate the association of adequacy of energy and protein delivery with outcomes in critically ill children. So this is another building in the Children's Hospital of Philadelphia complex. This is our new outpatient center, the Berger Center. And one of the really nice things I like about this is the very child-friendly architecture and the nice design that children love. And this, I don't know if you can see my mouse, but this is the rooftop garden, which is a therapy garden where we can go for relaxation and meditation, which is very important in the middle of our very busy lives. So I'm going to go to the first objective, which is timing of nutrition initiation. And I want to break it down as enteral nutrition versus parenteral nutrition, because these are two important aspects of what we provide as nutrition in the ICU. And within each component of nutrition, the question arises, is it early or is it late? So the first question, when should enteral nutrition be initiated, is a very important question. So recently, the American Society for Parenteral and Enteral Nutrition, as well as the Society for Critical Care Medicine, released guidelines for the provision and assessment of nutrition support therapy in the pediatric critically ill patient. And what they said was, on expert opinion basis, they suggested that EN be initiated in all critically ill children unless it is contraindicated. And not only that, they suggested please initiate it early within the first 24 to 48 hours after admission to the ICU. However, the quality of evidence is low and the recommendation grade was weak. And I'll get to that in a minute. So how did they form these guidelines? So these were some of the studies that they used to develop these guidelines. The first study that I want to highlight here was published in 2014, and this was published by Teresa Mikhailo from Wisconsin across multiple centers. She enrolled 5,000 subjects from 12 PICUs. This was a retrospective study with data collection going on for 6 quarters by all participating sites, as well as 8 ICUs contributed more data up to 8 quarters. The primary outcome here was PICU mortality. Now, one of the problems we are all faced with when we study the problem of nutrition and critical illness in children is less sick children are more likely to get enteral feeds, while more sick children are likely to get parenteral feeds. And that is what we call confounding by indication. So most studies you will see as I'm highlighting the evidence will try to adjust for severity of illness or some sort of a propensity score to account for the possibility that sicker kids are less likely to be fed enterally. And that is what they did in this study. So they defined early enteral nutrition as nutrition that is begun within 48 hours of admission to the ICU. And what did they find? This table shows the effect of early enteral nutrition on mortality. And you can see in this panel, if you go all the way to the right, once they adjusted for the propensity score, the severity of illness, age, and center, they found that early enteral nutrition was associated with lower mortality. And this held true not just for the entire population, but also when they excluded the malnourished patients, as well as mechanically ventilated patients included. They found the same effect. Not only that, they also found a trend in mortality with increasing enteral nutrition as a proportion relative to goal calories. they found that this was associated with improved survival, in other words, less mortality, suggesting that early enteral nutrition is very beneficial in the critically ill child. What about children requiring mechanical ventilation and or vasotherapy? These are the children that are the sickest in our ICUs, and they are here with either respiratory failure or cardiovascular failure or a combination of the two. Our group performed this study, which we published just earlier this year, where we examined early enteral nutrition in this cohort of children. This was a secondary analysis of nutrition support from our half-pint trial. We enrolled 608 subjects from 35 ICUs, and the data on nutrition was prospectively collected along with a guideline across all sites that emphasized early EN. The primary outcome here was 90-day mortality. And again, in our analysis, we adjusted for several confounders, including age, body mass index, Z-score, inotropic support, severity of illness, as well as PICU site and reason for admission. We defined early enteral nutrition as nutrition within 48 hours of critical illness onset. And this figure here has two panels. The top panel shows energy provided daily for the first 8 days, and the lower panel shows protein provided for the first 8 days. And the gray bars represent early enteral nutrition, while the white bars represent no early enteral nutrition, i.e. it was begun after 48 hours, as you can see here. And you can see there is a very nice separation of both energy and protein across the two groups. And what we observed was the early enteral nutrition group had much better outcomes than the no early enteral nutrition group. Particularly in terms of our primary outcome, you can see that the early enteral nutrition group did much better. This also persisted with our secondary outcomes, which was ICU-free days, hospital-free days, ventilator-free days, as well as organ dysfunction, where the early enteral nutrition group did much better. Are there any RCTs or randomized control trials, which is what we always consider our gold standard for any kind of scientific research? I'm happy to say that there is one randomized control trial that was done in India, and this was published in 2016, where the authors looked at early versus late enteral feeding in critically ill children. They enrolled 120 subjects and randomized in an open label fashion. 60 were randomized to the early EN group, which was within 6 to 24 hours of admission, and 60 were randomized to the late EN group after 24 hours of admission. The primary outcome here that they chose was the PICU length of stay, and the secondary outcome was mortality. And they performed a time to event analysis with a Cox regression model adjusted for severity of illness, malnutrition, and age. And what did they find? Sadly, they didn't find any difference in the primary outcome, which was duration of PICU stay. However, they found a trend towards decreasing mortality with early enteral nutrition that you can see in the lower row here. So again, this was a small sample size, so this was not powered for adequate detection of differences, but still very important data that we can now see is adding to the evidence. Now, I want to take a few minutes and break this down by specific subpopulations. We are going to first focus on acute respiratory failure and acute respiratory distress syndrome, which is quite common in our pediatric ICUs worldwide. In this study by Haney and colleagues, they enrolled 106 subjects in one PICU. This was a retrospective study with the primary outcome being length of stay. Again, they adjusted for severity of respiratory failure using measures of blood gas, severity of illness, as well as vasoactive agent use and age. They defined early EN as initiation within 72 hours of ICU admission. And again, they found that early EN was associated with a shorter length of PICU stay and a shorter length of hospital stay. This study by Dr. Janhao Lee and colleagues from Singapore, from a single hospital, looked at children with ARDS who were followed for 7 days of illness, with the primary outcome being mortality. Again, they adjusted for severity of ARDS, severity of illness, comorbidities, and adequacy of energy protein delivery in their model. They defined early EN as EN begun within 24 hours of ARDS onset. And again, in this cohort, they found up to a quarter of patients received early enteral nutrition. And they observed that the timeliness of initiating early enteral nutrition was associated with decreased mortality, as can be seen with these figures and statistics. What about sepsis? This is another very common, diagnosis that we have in our patients that get admitted to the pediatric ICU worldwide. It is a big problem. We are all trying to get better at recognizing sepsis early. And these guidelines were just released a few months ago, and it is being publicized everywhere in the world. And again, this group of international authors and investigators strongly highlighted that there is a preference to commence early enteral nutrition within 48 hours of admission in children with septic shock or sepsis-associated organ dysfunction who have no contraindications to enteral nutrition. So another common diagnostic category that we often see in our pediatric ICU is trauma, particularly traumatic brain injury, which is a very sad diagnosis and illness, and many children don't do so well. And our focus after the initial phase of management is often, how do we reduce the secondary injury and improve functional outcomes? And does nutrition play a role? And I'm happy to say, again, nutrition appears to be an important influence here, particularly enteral nutrition. So this was another secondary analysis of a randomized controlled trial of therapeutic hypothermia that was done in children with traumatic brain injury. Again, a multi-center trial that enrolled 90 subjects from 15 pediatric ICUs. The primary outcome was mortality. Notably, there was no specified guideline for nutrition therapy, and what the investigators did here was try to classify the timing of onset of nutrition into 4 groups. No enteral nutrition initiated within 48 hours, enteral nutrition initiated within 48 to 72 hours, and then enteral nutrition after 72 hours. Again, they used mixed effects models to assess the association of timing of enteral nutrition with outcomes in this study. What did they find? They found that when enteral nutrition was initiated under 48 hours or 48 to 72 hours, mortality was much lower. In sharp contrast, the group that got no enteral nutrition had a much higher mortality, as you can see, even though the numbers are very small, which we have to consider carefully in this small study with a limited sample size. In another study out of Wisconsin, this is actually my junior from medical school in New Delhi. He was 3 years my junior, and we were in the same hostel wing. So this is such a small world in our community. And I was so pleased to see him publishing in this field as well. Dr. Balakrishnan and his colleagues studied the same problem of nutrition initiation in children admitted to the ICU after traumatic brain injury. They enrolled 416 subjects from 5 ICUs, again looking at the primary outcome of mortality, and adjusted for age, severity of illness, ICU interventions, such as ventilation, vasopressor agents, medications, intracranial pressure, and Glasgow Coma Scale scores. And again, when they looked at nutrition initiation between children that had very severe traumatic brain injury versus those with moderate to mild traumatic brain injury, they found that the latter group, that is the mild to moderate traumatic brain injury group, tended to have early enteral initiation of feeds. And you can see that a greater proportion were fed by 48 or 72 hours in this group. But when they examined the outcomes associated with early and late initiation of enteral feeding, there was a clear advantage to starting enteral feeds within 48 hours. And this included those with severe TBI. You can see a shorter ICU length of stay, shorter hospital length of stay, as well as lower mortality in this column here. Lastly, I wanted to cover the evidence on probably our sickest group of children that many of our ICUs also take care of. These are the children that are supported on extracorporeal life support or extracorporeal membrane oxygenation, ECMO. This was again a group from Singapore led by Dr. Lee, who is one of our nutrition experts in the Asia Pacific region. And they enrolled 51 subjects from this one ICU and looked at the primary outcome of mortality. In their analysis, again, they adjusted for ECMO days, vasoactive agents, and renal dialysis. And what they observed was, though there was no difference in EN being initiated in the first 7 days in the non-survivors and the survivors, as you can see in this table, when they looked at time to EN initiation after ECMO started, the survivors tended to have enteral nutrition started much earlier. Now, one could say that these were less sick than the non-survivors, but as you see, they tried to adjust for ECMO days, vasoactive agents, and renal dialysis as markers of severity to highlight that there might be an independent effect of time to EN initiation, even in the sickest group. There are a few other studies that have examined nutrition practices in children with ECMO, and most of them have observed that very little EN is provided to this population in the first few days, with the majority of nutrition coming from the parenteral route. So with this, I hope I have convinced you that early enteral nutrition is very, very important in our sickest children, and they have numerous benefits compared to either no feeding or the parenteral nutrition. This is a view of the atrium of the Children's Hospital of Philadelphia from the inside. And it is so bright because there is a skylight above and all the natural sunlight can come in. It's a beautiful place for relaxation. And in the lower left-hand panel here is like a perpetual motion machine where things constantly are moving. It is fascinating for little children to watch. So I'm going to move on to the second part of my first objective, which focuses on parenteral nutrition. So when should we initiate parenteral nutrition? We talked a lot about enteral nutrition. Is there a role for parenteral nutrition? So again, we turn to the guidelines that were published in 2017. And what the guidelines state is that, based on a single randomized controlled trial, the recommendation for initiation of PN within 24 hours of PICU admission cannot be made. So in other words, please do not initiate PN within 24 hours of PICU admission. However, we all know that in the real world, it is rare to initiate parenteral nutrition within 24 hours of ICU admission. Usually this happens closer to 3 to 5 days or maybe even by 7 days. So the guidelines also go on to say that it is better to delay commencement of parenteral nutrition, and based on current evidence, the role for supplemental parenteral nutrition to reach a specific goal is not well known. Additionally, the timing for when PN should be initiated is also unknown. So therefore, the recommendation is this needs to be individualized by patient, by diagnosis, and by severity of illness, and most importantly, by pre-existing nutrition status. So these guidelines were formulated on the basis of this well-known study to most of you, which was published in the New England Journal of Medicine in 2016. Which compared a strategy of early parenteral nutrition versus late parenteral nutrition in critically ill children. This study enrolled almost 1,500 subjects from 3 pediatric ICUs across Europe and Canada. This was a randomized controlled trial of early PN begun within 24 hours versus late parenteral nutrition initiated after 7 days, with the primary outcomes being new infection and ICU dependency. The authors performed a time-to-event analysis with Cox regression models adjusted for age, severity of illness, risk of malnutrition, and diagnosis. And what they found was, to their contrary hypothesis, they found that the early parenteral nutrition group had worse outcomes compared to the late parenteral nutrition group, particularly in regard to new infections and ICU dependency. So they tried to then understand why this might be the case. And this was a subsequent secondary analysis that they did where they tried to break down the parenteral nutrition components by macronutrients. And you can see they broke it down by glucose, amino acids, and lipids. Amino acids are in red. And what they found very interestingly was the provision of parenteral amino acids seemed to confer more harm with a higher risk of infection in the early parenteral nutrition group. Whereas there was no effect of lipids, which is represented by the green triangles that you can see. There is no difference towards either harm or benefit. And surprisingly, they found that glucose or carbohydrates may have conferred some protection against infection, especially in the early days. So this raises the intriguing possibility that though protein is very important, perhaps the route of delivery of protein is even more important, i.e., enteral protein is probably the most important way to deliver it compared to parenteral protein. So this is something that needs to be studied further, and work is already underway to start doing some randomized trials to see if this is an important factor in terms of why parenteral nutrition has a lot of problems and difficulties associated with it. So we said that early parenteral nutrition at 24 hours is bad. So do we know anything about timing of initiation of parenteral nutrition? Sadly, we don't. The optimal timing still remains unclear, with severe malnutrition and high risk of nutritional deterioration being important factors to consider. So work still needs to be done on this important question. So if one were to think of a figure that could explain the timing of parenteral nutrition, one can refer to this figure here. The x-axis represents days, the y-axis represents energy, the black line on top represents total energy expenditure, the lighter line on the bottom represents endogenous energy production. And if you draw your focus to the first 3 days, which is in the gray panel, you can see that you have to start early initiation of enteral nutrition in stepwise fashion. But if we were to give parenteral nutrition here, which was done in the 5S study, there is a very high risk of overfeeding with parenteral nutrition. In contrast, once we go over to 6-7 days, we start accumulating more and more energy deficits because there might be barriers to advancing enteral nutrition. This is probably the right time to start supplementing with parenteral nutrition, especially if the gut cannot be used for a long time. In other words, if we do not do any additional nutrition at this stage, there is a high risk of underfeeding without PM. So this is a useful model to think about in our ICU population to prevent worsening nutritional deficits and protein deficits, which have harmful consequences for survivorship. So I hope at this point I've given you enough evidence to think about the timing of enteral nutrition and the timing of parenteral nutrition, which is our first objective of this talk. This photo here is a view of the main building of the Children's Hospital of Philadelphia at nighttime. And I often stand outside here and I try to view this, and it brings me a lot of peace just to see this beautiful building and how much work has gone in the last over 150 years in this beautiful hospital. I would now like to go on to our second objective to cover the adequacy of energy and protein delivery. So again, I'm going to turn to our guidelines that we have been referencing. And the guidelines very clearly state that the target energy intake in critically ill children should be to achieve delivery of at least 2/3 of the prescribed daily energy intake by the end of the first week in the ICU. Now, again, I want to draw your attention that the quality of evidence is quite low because these are all observational studies that are subject to a lot of confounding. And of course, the grade evidence is quite weak. When we think of protein, the evidence is slightly stronger and we have a stronger grade recommendation. On the basis of evidence from the RCT as well as the observational studies, the guidelines recommend a minimum protein intake of at least 1.5 grams per kilo per day in critically ill children, and perhaps even more to prevent negative protein balance. So I'm going to first look at this important study that talked about energy delivery. This was an international multi-center cohort study done by Professor Mehta at Boston Children's Hospital. This was published in 2012, and they enrolled 500 subjects from 31 pediatric ICUs. And it was a prospective cohort with prospective nutrition data collection for 10 days, with the primary outcome being mortality at 60 days. They adjusted for severity of illness and body mass index Z-scores in their analysis. And what they observed in the relationship between energy adequacy and 60-day hospital mortality was, once they adjusted for all the confounders, they observed that when energy was delivered in excess of 67%, there was a substantial decrease in the hospital mortality at 60 days, both unadjusted and adjusted. And they did this very elegantly by breaking down into tertiles, less than 1/3, 1/3 to 2/3, and more than 2/3. So they concluded that an intake of a higher percentage of prescribed dietary energy via the enteral route was associated with improved 60-day survival. They also observed that nutrition delivery is generally inadequate in mechanically ventilated children across the world, which is a big problem for us. What about the study on acute respiratory distress syndrome? Janhao Lee and colleagues also collected data on energy delivery in this study. And again, I don't have to remind you, we went through the background for this study, with the primary outcome being mortality and the regression adjusting for many confounding factors. What they found was, in this panel, the solid lines represent energy delivery as total calories per kilo in the red line and median percentage calories in the blue line. The solid line represents survivors, and the dashed line represents non-survivors. And you can see, as we go out across to a week, you can see that non-survivors tended to receive much less energy compared to survivors up in the top. Again, highlighting that it is not only important to start enteral nutrition early, but it is also important to provide the energy and get to goal within a reasonable time frame. What about the evidence in children supported on extracorporeal membrane oxygenation? Again,
I'm sorry, dear Professor Srinivasan, for interrupting you. We are just only 5 minutes with you. I'm so sorry for that. Thanks a
not at all.
million.
Thank you for letting me know. I'm almost done, actually. Thank you very much. So we again are looking at the practices in children on ECMO, and again we find in this same study, which I will again, you see the details here. When the multiple logistic regression was done, enteral nutrition adequacy was an independent predictor of hospital mortality, and actually was a protective risk factor, because with more EN, you had less mortality in this multiple regression model. This is another view of the Children's Hospital of Philadelphia. This big building here is the Research Institute. The building on the right side here is the Children's Rehabilitation Institute, known as the Seashore House. Lastly, I'm going to talk about protein delivery. And this study, again done by Dr. Mehta, was a multi-center study that enrolled 1,200 subjects from 51 pediatric ICUs. It was a prospective cohort that looked at primary outcome of 60-day mortality, the multivariable regression adjusted for PICU characteristics, patient characteristics, and nutrient intake adequacy. And again, what they found was, with increasing protein adequacy, the probability of mortality decreased in this large cohort, highlighting the importance of protein delivery. Similarly, the study by Janhao Lee that looked at children with acute respiratory distress syndrome, with the same statistical analysis and details that we have discussed, again observed that non-survivors with the dashed blue line tended to receive a lot less protein than the survivors with the blue line. So with this, I will pause and help you sink in and digest this information. I hope I've made a case for adequacy of energy and protein delivery. This is an artistic sketch of the Children's Hospital of Philadelphia from the main building. My final slide is on the take-home pearls. And I would like to emphasize that enteral nutrition within 24 to 48 hours of PICU admission is associated with better clinical outcomes. Parenteral nutrition within 24 hours of ICU admission is associated with worse clinical outcomes, but the optimal timing remains unknown. Energy delivery of at least 2/3 of prescribed needs by 1 week of ICU admission is associated with better clinical outcomes, and a daily minimum protein intake of at least 1.5 grams per kilo per day during ICU admission is also associated with better clinical outcomes. I would like to thank you all for your time and attention. It has been my pleasure to give this talk to such a wonderful audience, and I would like to thank you again.
Many thanks, dear Professor, for keeping the presentation in time, and also for your awesome lecture. I really inspired and really excited by the buildings, and it is, I think, the one of the best parts of your presentation, as much as all of the parts, all the informations, all the science inside. But so nice for us to see also the architecture of medical parts in Philadelphia too. Again, many thanks for giving us your time, and hope to see you soon. Maybe in Iran. We are wishing and hoping to host you in person here.
Thank you so much.
Thank you very much, Vijay. I was delayed for your speech. Sorry, I was engaged in another session that is going on about COVID-19. I just came here to thank you in person. Thank you very much, and I am honored to have you with us.
Truly my pleasure. Thank you so much. The honor is mine.
Thank you. Thank you very much. Thank you. Have a nice day. Bye.
Again, thanks a million for dear professors that shared us nice lectures. We are going to be with the dearest and the top speaker of the panel, Professor Christopher Duggan, that we are so honorful and so happy to have him with us from Boston Children's Hospital, USA. Dear Professor Duggan, so welcome to the panel, and many thanks for accepting our invitation. We are eagerly ready to have your presentation.
Great, thanks so much, Dr. Angari, Dr. Ehsan, and others for the kind invitation to speak. Dr. Srinivasan, very nice talk. I very much enjoyed the presentation, and I will add your name to the list of reviewers for AJCN, so we can have your input on some of the studies. We're trying to make the journal a little bit more applied and clinical friendly. So thanks for that great talk.
Thank you so much.
Let me. It says the host has
Professor
disabled
Duggan, just on behalf of our scientific and executive committee of this Congress, I am honored and I am humbled by your acceptance of this invitation. Thank you very much. And everybody is talking about you today in Tehran, and I'm so surprised that everybody loves you. Although many of our audiences never have been personally meet you, but everybody is talking about you, and we are eagerly waiting for your nice presentation.
Well, thank you so much for those kind words. I would. It is a pleasure to speak via Zoom, but it really is not nearly as good as speaking in person and interacting with people and hearing questions and comments. To say nothing of reading the body language of the audience to make sure that things you're saying are understood or perceived correctly. But we will make do, and hopefully someday I will get to visit in person, which I would enjoy greatly.
Sure.
So should I jump right in then and start? I was honored to ask to speak about diarrheal diseases, because indeed it is one of my true loves, and one of the reasons I became a gastroenterologist, actually. And what I thought I could do for today's lecture would be to review some recent findings in the fields of diarrheal disease research, with an emphasis on nutritional outcomes and interventions. I have no relevant financial relationships, and in fact, I'm not speaking really of any commercial products. So by way of outline, I'd like to talk a little bit about the role of diarrheal diseases in today's world. I'll transition to a review of the global burden of diarrheal diseases, evaluating the recent epidemiologic data on that topic. I'll spend a few minutes talking about a recently completed multi-centered trial that was recently published in the New England Journal of Medicine. It was called the Zinc Therapeutic Dosing Trial, that I think has some relevance for policy as well as for practitioners in the audience who are taking care of children with diarrheal diseases. And then I'll conclude briefly with some ongoing progress in future directions. So let's first talk about childhood diarrheal diseases today. And I think it's hard to give a clinical lecture or research lecture without addressing the pandemic and the role of the COVID-19 infection in health. And we now know that diarrheal diseases, diarrhea, vomiting are among the cardinal presenting signs of COVID-19 infection, actually. And this is not surprising because as seen in this figure, the SARS-CoV-2 virus does adhere to the small bowel enterocyte through the ACE2 receptor. And indeed, the presence of the virus in gastrointestinal the lumen there can cause diarrheal disease, and is a really important issue, not just with respect to treating patients and understanding the importance of diarrhea in children infected with COVID-19, but also our ability to track the progress of the virus in societies. And what I mean by that is the well-known ability of tracking COVID-19 with wastewater. And perhaps people in the audience have understood or read about efforts to delineate it. Certainly, if you map the epidemic based on who can come to a testing site and get a nasopharyngeal culture, then you are automatically biasing your estimates based on those people who leave their house and seek medical care. But indeed, tracking the virus exposure through communal assays of wastewater is an effective way of mapping the epidemic throughout diverse geographic and perhaps economic strata of our society. And indeed, the same approach was useful when people were tracking down polio epidemics, right? Instead of seeking out every individual child with infantile paralysis, people use this aspect of epidemiology to pin down outbreaks that way. So stay tuned for more data on the importance of the gastrointestinal tract in the handling of the COVID epidemic. Well, speaking about more, garden variety, if you will, gastrointestinal infections, I think it's important to realize that children with diarrhea have watery stool. And so this is the typical rice water stool from a patient with cholera. Cholera is, Vibrio cholera is well known to everyone in the audience, a bacterial infection that can cause very acute and severe dehydration. And if not treated, can lead to death. And this is a child being treated at the ICDDRB, the International Center for Diarrheal Disease Research, in Dhaka, Bangladesh, and you can see that this child has signs of severe dehydration, a prolonged skin fold, a altered mental status, sunken eyes, and a very dry mucous membranes. And indeed, the children such as these presenting with severe dehydration are every day treated successfully at centers like the one in Dhaka. And it all boils down to accurate measures of input and output. You can see that this child is positioned on a bed that has a sleeve, and through that sleeve we collect, or physicians in Dhaka, I should say, and nurses collect stool output in the bucket, and it's only through that approach that they can accurately and validly measure ins and outs. And indeed, as we all know, the efficacy of oral rehydration solutions for the management of dehydration due to diarrheal diseases has been well established. It's been called by the Lancet perhaps the most important medical breakthrough of the 20th century. And it does boil down physiologically to the presence of the sodium glucose cotransport molecule SGLT1 on the apical border of the epithelial cell of the GI tract. It's therefore important that the composition of the oral rehydration solution be composed of equimolar concentrations of sodium and glucose. And one of the main messages and methods of gastrointestinal physiology, of course, is where sodium travels from the lumen of the GI tract into the bloodstream. So therefore water follows. Water follows across the epithelial cell as well as between epithelial cells. And so this is really the physiologic basis of oral rehydration solution. For many years, the World Health Organization proposed a solution that was really driven by studies that were done in India and Pakistan and Bangladesh, where cholera was an important cause of dehydrating diarrhea. So the sodium concentration of the WHO ORS for many years had 90 milliequivalents per liter of sodium. And a little bit higher concentration of glucose, so close of a 1-to-1 ratio, but a little bit not optimal. And indeed, the osmolarity of the standard solution was somewhat higher, a little hyperosmotic solution compared to blood osmolarity. So now 20 years ago, colleagues and I put together a series of studies that evaluated the so-called reduced osmolarity oral rehydration solution, in which the sodium was mildly decreased, the glucose was moderately decreased, so that the 1-to-1 ratio continued, but the total osmolarity of the solution was less than 280 or 290. And so this was tested in a variety of children and adults with and without cholera, and found to be equally efficacious, and in some cases better than the WHO solution in terms of less vomiting and less need for supplemental IV fluid. So this reduced osmolarity ORS a few years ago was named the standard by UNICEF and WHO. Now, the beauty of treating children with diarrhea, of course, is that it can follow a very strict but well-accepted pattern of triage of a child who has minimum or mild, moderate, or severe dehydration based on the picture of the child that I showed a couple slides ago. And these treatment guidelines really have been well established, and thankfully can be provided by oral rehydration can be provided by mothers as well as allied health personnel, which is really important. But I always point out that these kind of cut and dried tables are no comparison to seeing clinically how a child with dehydration is treated. So these series of photographs were taken by Bert Hirschhorn and Bucky Greenow, who were longstanding investigators in the field of oral rehydration solution. And they're actually taken at a hospital in Cairo, Egypt that I worked at for a year I think they were taken the year before I arrived. It was back 30 years ago. And indeed, everyone knows in Cairo that the hospital to go to if your child has diarrhea is Abu El-Rish Hospital. So every morning we would go to work, and mothers, largely mothers, sometimes fathers, would be lining outside the door waiting for appropriate therapy. And I always like showing this picture, especially to my colleagues in Boston and probably Philadelphia, to say that if a child like this showed up in our emergency department, we wouldn't attempt oral rehydration solution. Certainly physicians would jump right to intravenous solution, or perhaps more accurately, interosseous solutions, because getting venous access to a child with this degree of dehydration could be difficult. So just to review, the child has a sunken fontanelle, which parenthetically is not the most reliable measure of dehydration, but can be in some children. Sunken eyes, and decreased mucous membranes. But with oral rehydration solution given steadily in slow volumes, you'll see what happens. So this is at 9 o'clock in the morning, where our assistant as well as the mother are tending to this child. At 9:15, you can see the child is thirsty still, avidly drinking the oral rehydration solution. By 10 o'clock, seemingly better hydrated. The eyes seem a little bit brighter, perhaps less sunken, but still avidly drinking the solution. And by noon, 3 hours in, you can see really a new child. This is a child with no longer a flat fontanelle and quite rehydrated, and such at 1 o'clock is back nursing. And so this kind of miracle, if you will, of the effects of oral rehydration solution are perhaps what's responsible for a substantial decline in mortality due to diarrheal diseases, which I'll segue into the second part of the outline, which is reviewing some of that data. And indeed, these are very fine point estimates without confidence intervals, but suffice it to say that UN and UNICEF and others have estimated that the number of childhood deaths overall, despite an increase in childhood population throughout the world, of course, is declining substantially. So in 1990, the total number of childhood deaths of 12 million or more, at least half of that, 5 to 6 million of those deaths were thought to be related to diarrheal diseases. And as I'll show in a minute, the estimates of child mortality due to diarrheal disease is substantially less now, perhaps as low as 500,000. So whenever I quote that figure, that there's been reduction from 5 million deaths per year to 500,000 deaths per year, it's a good news, bad news situation. The good news is, of course, any reduction in child deaths should be applauded. But the bad news is 500,000 children dying per year is still a considerable number. And to the extent that these children are often dying from preventable causes is really a terrible thing. This paper published in the Lancet now 10 years ago, is an important one for a number of reasons. Number one, there are really interesting graphs in this paper that I'll get to. Number two, when one thinks about childhood deaths, it's really hard to ignore a country with such a high population as India. So when a country has 20% of the world's childhood deaths, it's really it's hard to ignore kind of patterns of those mortality rates because they have such a high impact on global figures. And number two, this study, as many studies do, kind of break down the etiology of childhood deaths in the classic kind of pie charts, where essentially the gray slices of the pie represent childhood deaths in the first 30 days of life, so-called neonatal deaths. But the other part of the pie are postnatal deaths, but deaths that occur before age 5. And the reason that I think that this sometimes gets us off on the wrong approach of estimating underlying causes of death is the fact that these pie charts were often drawn by your typical pediatric subspecialists, be they neonatologists, be they infectious disease doctors, be they gastroenterologists, be they pulmonary doctors, etc. And I think that is an unfortunate way to look at this pie, because I'm obviously very interested in nutritional causes of death, and indeed undernutrition is the underlying cause of many of these infectious causes of death, perhaps 45% of them. So caution, if you ever see a pie chart like this, always remember that the proximate cause of death may not be the same as the underlying cause of death. So I mentioned that this paper had very interesting figures, and let me just show you that this is one of the figures that shows in a time-lapse way what the under 5 mortality within the entire country of India, broken down not just by the many states of India, but by the various districts within the states. And as you can see, it's not an equal distribution. So if you look in 2001, what the under 5 mortality rate per 1,000 live births, you can see that it's 80 in much of the central areas of the country and in some central areas of South India, but it was less than 60 in 2001 in some of the western coastal areas, which are perhaps economically more developed. So that kind of makes sense if we think that child mortality is related to a moderate degree to economic development, education, and other aspects that are related to health outcomes. But what's interesting is that just in 10 short years, if you look at the map in 2001 versus the map in 2012, there's been a really sharp and really impressive reduction in all-cause mortality, such that the red zones are almost extinct. They're still present in some of the poorer areas of the central states in the country, but there's really been a sharp reduction in childhood mortality. So if you look at the data, the total number of under 5 childhood deaths has gone from 96 to 57 per, excuse me, per 1,000 live births. So this is really an impressive job by the country, but does bring up several other questions with respect to equity, with respect to gender distribution of these gains in child mortality, which I'll show in the next figure. So this is a somewhat of a complicated figure, but it basically looks at female to male ratio of mortality in the first 5 years of life. And it would be unusual for a biological illness such as diarrhea or pneumonia to cause a 50% higher mortality rate in girls versus boys. But indeed, that's what we see in scattered states throughout the whole country, not centered as the other graphs were in the central areas, but actually this difference in mortality rates favoring boys to girls, it's really quite substantial and certainly of note, and calls into question, of course, access to medical care as well as access to preventive health services, including vaccines, oral rehydration solutions, and others. So the tabular presentation of this data are noted in this table, and just focusing on the lower half of this table, let's just look at deaths from diarrheal disease in the country of India, broken down by where in the country they're located, these states are located, as well as whether the boys or girls are dying from diarrheal disease. So point number one is that there's huge geographic distributions, variety in terms of the mortality rate per 1,000 live births, depending on whether a child is born in the western states, south, northeast, or northeastern states. And indeed, these central states represent a huge high proportion of the deaths, as shown by this figure, substantially higher than the rest of the mortality rates in other states. And then if you compare boys in these western states, who overall have a much lower mortality rate, so 4 deaths per 1,000 live births, and then you compare that graphically with girls, children in the central states of India, where mortality rates are almost 5 times that, 17 or 18 per 1,000 live births. You can see we almost run off the space of the figure. There's just a huge disparity in both gender and geographic distribution of deaths in the country. And I think India is probably just one example. So not only are preventable deaths not equally distributed around the world, but actually these deaths are not equally distributed among countries and among boys versus girls. So food for thought there. I mentioned previously that the estimates of diarrheal disease deaths are as low as 500,000 children per year. And so that's obviously a very important milestone, and many researchers have estimated how we can bring that death rate down to 0. And UNICEF points out that deaths from pneumonia and diarrhea, which obviously parallel and have many joint risk factors, that 1 death is too many. And so a nice graph that shows overall deaths from pneumonia are declining by half, by 47% decline over the past 15 years. Diarrheal deaths used to be 1.2 million, and now they're estimated to be 500,000, so a substantial decline in that as well. Indeed, sepsis seems, and this is often neonates, neonatal sepsis hasn't declined as quickly. Pertussis, tetanus, and meningitis, measles, and AIDS, you can see substantial reductions in all cause in these different etiologies of child mortality. And I think the other thing that I always point out when talking about global health and child deaths is the fact that if you were to survey the average man or woman in the street and ask them, well, what are the most common causes of childhood death in 4 countries, you might actually get different answers. Very few people would estimate that pneumonia, diarrhea, and bacterial sepsis are the top 3 causes of childhood death around the world. HIV disease, measles, malaria, those causes seem to be most prominent in many people's minds, but in fact, pneumonia, diarrhea, and sepsis are the top 3 causes of childhood death. So let me talk a little bit about zinc supplementation and its role in managing children with diarrheal diseases. And as pediatricians and medical trainees will remember in our training that 99.7% of our body is made up of a variety of different but limited number of elements when you think about it. And so therefore, because of the small proportion of these elements contributing to the rest of body composition, we call them trace elements. And indeed, nutritional roles have been identified for most, but not all of these elements. So iron, iodine, zinc, copper, etc. They're important components of the way in which we provide parenteral nutrition, for instance. There are less clear roles for nickel, palladium, silicon, arsenic, and boron, and certainly aluminum and lead are thought to be toxins. And indeed, we do follow aluminum levels in children who are dependent on parenteral nutrition for long periods of time. But zinc is one of these nutrients that really has a wide range of roles in numbers of different physiologic processes. It's an important component of hundreds of different biochemical enzymes, including alkaline phosphatase. So that's the classic question on pediatric board exams. A child presents with undernutrition and a low serum alkaline phosphatase. That seems to be consistent with zinc deficiency. Carbonic anhydrase is an important enzyme in maintaining acid-base balance. So zinc deficient patients can tend to be acidotic. And DNA and RNA polymerases. So perhaps the reason why children who are zinc deficient are not growing as well because of the lack of impact, the impact of zinc deficiency on DNA polymerization. It is a weak antioxidant. It protects against lipid peroxidation. And unlike other micronutrients that have been found to be important for child health, such as vitamin A, and its location in the liver, zinc does not really have a specific store in the body. And so both because of gastrointestinal toxicity, as well as that fact, high dose zinc supplements are not usually an effective way at improving zinc nutritional status. Well, indeed, in speaking to you as folks in Iran about zinc, it's the classic bringing coals to Newcastle, as they say. Zinc deficiency, as many of you in the audience know, was first described in Iran as well as in Egypt. This Dr. Ananda Prasad is often referred to as the father of zinc nutrition, and he, Dr. Halstead, and Dr. Nadima, the Nadimi presented really a very influential case series of adolescent boys who were short, stunted, undernourished, and found to have many of the biochemical features of zinc deficiency. So I would, even to the non-historians in the audience, I would commend this paper to your reading. And indeed, this idea that children who are living in countries where the diet was low in animal source of proteins and high in cereals that may have delayed or reduced the bioavailability of zinc really gained credence in the 1960s. And so when you think about it, really it's not been that long that people have understood the importance of zinc nutrition in child health. There is a rare cause of zinc deficiency called acrodermatitis enteropathica. I should have included a recent picture from the New England Journal of Medicine that showed that very graphically. People who are on long-term parenteral nutrition but are not receiving trace elements can develop zinc deficiency. And people who have increased metabolic demands for zinc, either because of burn injury, Crohn's disease, or other inflammatory or malabsorptive processes, can be at risk of zinc deficiency. And certainly children with severe acute malnutrition are likely to be zinc deficient. And unfortunately, here's a difficult picture to look at that basically shows the classic rash of zinc deficiency. And so a rash in the diaper area as well as a rash around the mouth. And indeed, this child has the kind of scaly paint presentation of kwashiorkor as well, with severe acute malnutrition. You can see wasting here. But that's perhaps the tip of the iceberg. And indeed, there have been many studies that have looked at critically at the role of zinc deficiency in immune function. And because of the presence of zinc in numerous different enzymes, there really isn't any arm of the immune system that's not affected by zinc deficiency, actually. And in this very nice review by Anu Shankar and Dr. Prasad, they basically reviewed that every animal study or human study really showed that this was the case, that zinc deficiency had an adverse effect on immune function, which led to a series of studies that basically evaluated the role of zinc intervention on diarrheal diseases. I already mentioned that obviously acute congenital zinc deficiency can be treated with both parenteral and enteral zinc supplementation, but indeed a number of different intervention studies, as summarized here, as well as two pooled analysis, suggested that in countries where children were at risk of biochemical zinc deficiency, either due to poor diet or poor bioavailability of the zinc, that zinc supplementation was associated with decreased duration of diarrhea, as well as the decreased risk of the diarrhea turning into persistent diarrhea and resultant malnutrition. But I included in the slide the RDAs for zinc, just to remind you and me that actually in early infancy, the recommended dietary allowances for zinc is actually on the order of 2 to 5 milligrams per day. And the very interesting thinking about a number of these different studies, including the classic study by my colleague Sunil Saswal in the New England Journal of Medicine in 1995, is that they used a zinc dose of 20 milligrams per day. So up to almost 10 times the dose of the 10 times the RDA factor. And they did this because of the realization that when you give a high dose zinc in children who are already malabsorbing zinc due to acute diarrhea, the net absorption may actually be much less than the full 20 milligrams. But it was not really done with an eye towards what the physiology would be when you give a child that high dose of zinc. So keep that thought in your mind as we review briefly this idea of an influential Cochrane meta-analysis by Lazzarini and Wanzira, which basically reviewed a number of different studies. So 9 trials of 2,500 children, as well as 5 trials of children with malnutrition. And you can see the duration of diarrhea was statistically significantly lower in all trials. But it's hard to get excited really about an 11-hour difference in duration of diarrhea, of course. However, when you look at children with malnutrition, it turns into more than a day less of diarrhea. So that's impressive. And as I alluded to, a 27% reduction in the risk of diarrhea existing still on day 7. And as we all know, the duration of diarrhea really has a high impact on the nutritional status of children. So basically people were very excited to review these data and suggest that a policy change should occur. And indeed, in 2006, UNICEF, World Health Organization, Johns Hopkins, and USAID put together two of the points that I've made earlier in the talk. One is the universal use of the new low osmolarity ORS should be recommended. Was recommended in 2003, but this is UNICEF's restamp of approval in 2006. And then caretakers should also be provided with enough zinc supplements to continue home treatment for 10 to 14 days. And indeed, I'd be interested in knowing in the discussion section how often this recommendation is performed in Iran, because I have no firsthand knowledge of that. But certainly for countries where diarrheal disease burden is very high, including countries in South Asia and Sub-Saharan Africa, this has been widely used as the policy, and many ministries of health have accepted these as standard approach. But flipping back to the Cochrane analysis, I did want to point out that tucked away, if you will, on page 2 of the summary, if you look at adverse events and vomiting, there's actually a substantial higher risk in children who are receiving high dose zinc supplementation for diarrheal disease to have that exacerbate their episodes of vomiting. So 6 trials studying 2,600 children, moderate evidence that there was a substantial, 57% increase in the risk of vomiting. Interestingly, no comment was made, and indeed this was generally not appreciated as a significant problem. But you can imagine if you have a child who's vomiting already, the idea of giving them a zinc supplement that might increase the risk of vomiting was probably something we should have paid attention to. So it took us a while, but my colleagues and I both in Delhi, India, Dar es Salaam, Tanzania, and at the World Health Organization did formulate and carry out a randomized controlled trial in 2 countries where we evaluated 2 different doses of zinc for childhood diarrhea. Our goal was to identify the optimal dose of zinc in children under age 5. And we basically compared the standard dose of 20 milligrams per day to 2 lower doses of zinc. One was 5 milligrams per day and one was 10 milligrams per day in children presenting under age 5 with acute diarrhea. And we measured that efficacy just in terms of the percentage of children with diarrhea lasting greater than 5 days, as well as the mean number of loose or watery stools during follow-up. And the safety outcome was really related to this risk of vomiting. And we measured vomiting both 30 minutes after the receipt of the supplement, as well as subsequent vomiting during the course of the follow-up. And so Tanzania, as I'm sure you know, is a beautiful country in East Africa. The study took place in Dar es Salaam, which is on the port. It's about a country of 50 million people with a moderately depressed life expectancy, unfortunately, because of economic status of the country, as well as a high rate of infectious and other illnesses. The rate of childhood underweight or low weight for age Z-scores is about 16% by age 5, and the rate of stunting is about 45%. So you can see this is a nutritionally vulnerable population for whom zinc supplementation may well be an important component in reducing all-cause morbidity and mortality. Diarrheal diseases are estimated to cause about 10% of all infant deaths, and we had preliminary data to suggest that children had frequent episodes of diarrheal disease. So this study was just published in August, where we compared the 3 arms of different zinc supplementation. We assessed at 2 sites, India and Tanzania, for eligibility about 5,600 children. 4,764 met the eligibility criteria. 4,500 were randomized into one of 3 arms. So the standard arm was 20 milligrams per day, and the 2 lower arms were 10 and 5 milligrams per day. And I really take my hat off to my colleagues both in India and Tanzania, where, as you can see, it's a little small font, I apologize, but efficacy follow-up was 100% in all of the 3 groups, and safety follow-up was available for 100% as well. So we really did a great job of following these children up. In terms of diarrhea outcomes, the efficacy of the 2 arms, and then the proportion of children who had diarrhea greater than 5 days on an intention to treat basis was 7.2%, 7.7% in the 2 experimental groups, and was 6.5% in the 20 milligrams group. This was a study that was designed for non-inferiority, so a low p-value in this analysis means that we reject the null hypothesis, and we confirm that these two arms were not significantly different than the standard group. So we did feel that the two lower arms gave similar efficacy results. And this was true whether we measured diarrhea lasting for more than 5 days or the total number of loose or watery stools after enrollment, which in the three groups was 10.8, 10.9, and 10.7. As you can see, quite similar. And again, the p-value for non-inferiority suggested that these were not different from each other. In terms of vomiting outcomes, we measured vomiting, as I mentioned, both any vomiting within 30 minutes of giving the dose of zinc. And as you can see here, the proportion of children vomiting was 13.7% in the 5 milligram group, 15.6% in the 10 milligram group, versus 19.3% in the 20 milligram group. So substantial reductions in vomiting with respect to lower dose zinc, a 29% reduction and a 19% reduction in relative risk of vomiting. And this was true also when we compared all vomiting, not just within 30 minutes, but anytime during the study. A 26% and a 17% reduction in the risk of vomiting in the two lower dose groups compared to the standard group. And then to confirm that our standard versus lower dose zinc groups had a dose response, if you will, in the blood, you can see that they differed substantially with respect to plasma zinc over time. Obviously, it was a 14-day intervention, so not surprisingly, plasma zinc at 21 days and 28 days after enrollment were comparable between the three study arms. So we concluded that children with acute diarrhea receiving 5 or 10 milligrams per day of supplemental zinc had outcomes that were similar to those in children receiving 20 milligrams per day, but had less vomiting. And we suspect that global recommendations will be changed to reflect this better safety profile. And more importantly, if caretakers and mothers realize that zinc can help improve diarrheal outcomes based on our previous data, but have less vomiting, it might lead to better uptake in supplemental zinc. So I see that it's on my time 10:48, so I'm going to ask the conference organizers whether you would like me to proceed with my lecture. I have a few more slides, or would it be better to pause here and take questions?
Dear Professor Duggan, I don't know how many your remaining slides would be, because we had to start the psychiatry panel 3 minutes ago, but because your presentation is so nice and it's so exciting and interesting, none of us would like to interrupt it. I put you as you wish.
Well, I'm so sorry to have gone over my allotted time.
Never.
And so why don't, so if we, so I will, maybe I'll just jump to kind of why don't I just jump to the end here. Thank all my colleagues in Dar es Salaam. Thank all my colleagues in both India and Dar es Salaam, as well as WHO, and suggest that it's children like this that we help to improve their life free from diarrheal disease. I'll end my talk and ask if there's any questions.
Dear Professor Duggan, I'm so inspired with the end part, especially. It's so nice. And thanks a lot again for accepting the invitation, for being with us. We know that you are so busy, and this is so precious and so valuable for us to giving your time. Thanks a million. Just we have one question here. Someone asks that, let me find it, sorry. Is there any relation that gluten-free diet may reduce TG and diarrhea?
Gluten-free diets would reduce what, sorry?
Is there any relation that gluten-free diet may reduce TG and diarrhea? Triglyceride. I know.
Triglyceride, like
and
hypertriglyceridemia? Hypertriglyceridemia?
Yes, exactly.
No, actually, I think just the opposite. Actually, gluten-free diets can be low in fiber and therefore high in fat, and so I would suspect the opposite might occur.
Thanks a million. If you have any comment, if you have any thing to share with us, we're glad to hear.
Well, let me just ask, how frequently are children in Iran receiving zinc supplementation after acute diarrhea?
I ask dear Professor Ali Madadi to answer your questions because I'm not qualified even to talk about this issue, but Professor Ali Madadi is our professor of gastroenterology, pediatric gastroenterology, and I know that your answer is in his hand. Maybe he's going to answer in chat section or maybe to you. Professor Ali Madadi, would you please answer the question if you hear us?
Hello, Professor Duggan. Thank you for your useful presentation. In our country, we recommend zinc supplementation 20 milligram per day for 10 to 40 days, 14 days for gastroenteritis in children above 6 months old.
Yes, yeah, okay, so that's great. That is the WHO recommendation, and I don't want to predict how WHO will interpret our data, but I suspect that changes in the dose might be coming, so stay tuned for that.
Again, thanks a lot. Thanks millions to our dear lecturers, dear Professor Borna, dear Professor Amita Trehan, dear Professor Srinivasan, and dear Professor Duggan to be with us all during the session. It's so nice to see you. It was a big chance for me to see you and share this panel with you. I'm so honorful and hope to see you one day. Wish to host you in Iran. And many thanks. Take care. Have a good day. Have a good time.
Thank you. Thank you so much.
Thank you.
Thank you so much.
Dear audiences and dear participants, we are going to be with you with the psychiatry panel in just few seconds. Thanks a lot for being in this panel, for sharing comments and questions into the chat section. I want to just a little bit remind that you can, for Iranian audiences, if you need CME credits, please go to CME quiz and pass the panel's quiz for being qualified for the panel and get the credits. Thanks a lot. Have a good time all. I'm passing to the next manager for the psychiatry panel. Goodbye.